but there are lymph glands throughout the body, in the back of the neck, the back of the chest, and the abdomen, the groin, in several areas. And there are, of course, loose lymph cells as well. What we are looking at is the lymph gland contents, which is the cells, which we call lymphocytes, which have become cancers. So when the lymph cells in the lymph gland become cancers, we call it lymphoma. Are we able to see the slides?
I think the
So with that,
is visible, sir. Yeah, you can go ahead.
okay, thank you. So with that short introduction, I'm going to ask you to advance the slides. You can go to the next one. Obviously, this is in general, what I want to tell you is that there are all kinds of lymphomas. Heterogeneity means it's very different. I mean, the other word for it is diverse, but we use heterogeneity in the setting of cancer. We will understand why a normal lymphocyte becomes cancers, and how, when they become cancers, they retain some of the structures of the normal lymphocyte that allows us to identify them. And also, based on the patterns, we're able to give a name to the type of lymphoma. And of course, there is going to be this very step-by-step approach. It's a systematic approach to lymphoma diagnosis, and we'll maybe just give you a patient case and then close thoughts with that. Next slide, please. Okay, so if you look at lymphoma in general, broadly speaking, the cancer of the lymph cells in the lymph glands. And I emphasize lymph cells in the lymph glands. The gland itself is not cancerous. It's the contents of the lymph gland which is cancerous, right? So there are two types. The first discovery was Hodgkin's. Hodgkin's discovery happened many, many years ago. And this is, and of course, it's an eponymous name based on the person who discovered it, right? And it is based on the, and I'll show you in the next slide, I'll show you based on the cell they saw under the microscope. Historically, in the invention of the microscope and doing anatomy, and I think the doctors 100 years ago were doing many things at the same time. They're taking care of patients, they're doing autopsies, they were giving birth to, so it's a diverse functional approaches. Today, you're a specialist, you only do one thing, right? In those days, they were doing everything, including autopsies. And Hodgkin's first saw this under the microscope. He saw a big cell. It's called a Reed-Sternberg cell, right? Maybe if there is a way to ask questions, I could ask you. I don't see the audience, but in any case, the Reed-Sternberg cell was what the eponymous name was given to. Everything else that didn't have this Reed-Sternberg cell is called non-Hodgkin's lymphoma. So simple, right? Simple classification. Hodgkin's, non-Hodgkin's. And in the non-Hodgkin's, there are two big groups, which is B-cell lymphoma, because it comes from B cells. And that's the most common type of B-cell lymphoma. And then the T-cell lymphoma, which is rare. And so altogether, there are about 70 or 80 types of lymphoma that we can see across the board. And it's the number 7th cancer in the United States, and across the world, the Globocon. Globocon is the global survey of cancer. And they came up with the analysis that the lymphoma is very high in the list, and for various reasons, because certain lymphomas are actually caused by viruses. Viruses can cause lymphomas, like Epstein-Barr virus can cause lymphoma. This lymphoma is associated with hepatitis. This lymphoma is associated with HTLV. So there are 3 or 4 viruses that cause lymphoma. For the most part, we don't know why it happens. And there's one lymphoma which can actually be cured with antibiotics. Do you know which kind of lymphoma in the early stage? Okay, so it's gastric lymphoma or malt lymphoma, MALT, and very early involvement of the stomach. And it's caused by a bacteria called Helicobacter pylori. So Helicobacter pylori causes that lymphoma in its early stages, you give antibiotics and it goes away. So these are some of the examples of bacteria and viruses, but they are not common. The most often reason why we think lymphoma happens is because these lymph cells get exposed to chemicals or other unknown materials that cause the lymph cells to get signals, and they expand, they proliferate, and become cancers. Go to the next slide. And these are additional epidemiological information. Of course, this is from the US, and in general, it's true for the rest of the world. Hodgkin's lymphoma is not as common as the B and the T cell lymphomas. The B cell lymphomas are the most common. Hodgkin's lymphoma is about 2,000 new diagnoses every year. And the Hodgkin's lymphoma itself is seen in young patients and older patients. So we call it bimodal. It's present at two different age groups. It's in the second decade and also in the sixth or seventh decade of life. And there are various treatments that have changed the outcome. And today, Hodgkin's lymphoma is a curable lymphoma. Very important to remember, because you diagnose this very early, and a lot of them are in the 20s. They get diagnosed, and when you identify this and give the right treatment, which used to be radiation in the 1960s and 70s, and then chemotherapy. And then now we have immunotherapy that has changed dramatically the outlook and also the side effects and the long-term effects. And most people have normal lifespans. So it's very important to know that. Next slide. So this is the cell that I was talking about that led to the identification of Hodgkin's lymphoma. This is called the Reed-Sternberg cell. These are characteristic cells. They have two large nuclei. It reminds you of something, right? It reminds you of the owl. If you look at the two large nuclei staring at you. So it's called owl. Two scientists called the thing about the Reed-Sternberg cell is that it's just one cell that is cancerous, and every other cell around it is not. It's all reactive. Sort of like one dictator that is trying to co-opt all the other cells in the lymph node to act according to his or her wishes. And so that's how the Hodgkin's lymphoma is. So a lot of the Hodgkin's lymphoma is reactive. But if you find a few of those Reed-Sternberg cells in a lymph gland that is enlarged, that defines the Hodgkin's lymphoma. Next slide. Okay, so we'll talk about some of the key events that allow this lymphocytes to become cancerous. So we'll go to the genetic organization, a few principles, and then hallmarks of cancer, which all of you should know, the medical students should know. It's been work that's done over a span of 20, 30 years. Everything that we know about cancer is now broken down into 10 or 11 principles. Okay, next slide. So the hallmarks of cancer is presented by Weinberg and Hanahan. Weinberg is a cancer center director at MIT. And you can see that one of the first things that the lymphocytes, once they become cancerous, is they want to grow. They have sufficient, there are checks and balances in the body, which means some cells try to grow. It's a crowded situation in the body, there are trillions of cells, and a few million cells are trying to multiply. And so what happens is there are anti-growth signals. But then what these cells do is that they develop escape mechanisms against anti-growth signals. And the third thing that happens is that these cells are destined to die. They evade the process of cell death. So cell death is called apoptosis, and they evade apoptosis. And they acquire this endless potential to replicate. In some ways, cancer cells want to be immortal, right? So, is it better now?
We are losing you briefly, sir. Very few echoes, and briefly, I think some of the audio is dropping. I think it's due to the technical work issue, but we are able to hear most of it.
Okay. Let me know. I can repeat it. You can always raise your hands or let me know.
It's clear now, sir.
Okay.
You can go ahead,
Eh,
please.
okay, good, good. So limitless replicated potential. And then they want to escape from the local area. So they get into the blood vessels. So they actually develop new blood vessels. It's called sustained angiogenesis. And they then invade other tissues. They want to escape and conquer new worlds. That's called metastasis. So these basic six principles are some of the key aspects of the behavior of cancer. This is work of thousands and thousands of publications that has been condensed into six principles of cancer called the hallmarks of cancer. Next slide. Okay, so there are some emerging landmarks also. In addition to the six, the cells use energy. Oftentimes there's a misnomer that cancer cells like glucose. Which is not true. They're very inefficient. So their energetics, the metabolism is very disrupted. So that is something we can see, and we also exploit that by using certain scans called the PET scans. And the next thing is that the genes are mutated. They're mutated, and I'll show you some examples of that. And they also promote inflammation, like the Hodgkin's cell. It promotes the cells around it to grow with signals asking to protect it. So you have this tissue inflammation. And finally, there is the immune system. The immune system is supposed to protect it, but the immune system is made helpless. You see the immune cells, it's like if you think about it, you have thieves trying to rob a bank, and you have the police, and they cannot do anything. They've taken the guns away, and the police are just watching helplessly. Similarly, you have this avoiding the immune destruction that happens with time. So 6+4 principles, remember this, and these are very important publications that has led to at least 30 Nobel Prize uh, 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 discoveries that has led to this. And today, some of the therapeutics are based on this. For example, we are talking about immunotherapy for Hodgkin's lymphoma. But just by trying to make the immune system work better, we're able to cure many types of Hodgkin's lymphoma. And it's also true for other cancers which we didn't think we would be able to treat, such as melanoma, such as lung cancer, breast cancer, ovarian cancer, etc. So that's been one of the biggest principles. And it so happens that at MD Anderson, where I am, one of my senior colleagues, Dr. Jim Allison, won the Nobel Prize for discovering this principle that these cancer cells are exhausted. And so you actually make the cancer cells a little bit more energy by taking the brakes off, and you're able to drive these immune cells to attack the cancer cells. And so it's very inspiring work that is done. Next slide, please. Okay, so basically, all cancers are genetic disease, and I won't spend much time on this. And just to show you that the genomics of it, every cell is hardwired and coded to the genomic principle, the ATGC or the CAGT. And the next slide. And what happens with cells that are trying to multiply very fast is that you have pieces of chromosomes that go off in a different direction because they're multiplying so fast. Errors happen in multiplication. Pieces of chromosomes, there are 23 pairs of chromosomes, and numbered 1 to 23, and the 23rd decides male or female. So 1 to 22 are very important in cancer. Pieces go off in different directions during the process of division or multiplication. And then you can get amplifications, you can get aneuploidy, you can get translocations. See, these are some of the examples. Not so common in lymphoma, but there are certain types of lymphoma, for example, Burkitt's lymphoma, where this is very common when a piece of chromosome from 8 goes to 14. And that is the classic Burkitt's lymphoma, and that causes the cells to multiply very fast. And by the way, in Burkitt's lymphoma, some of that process of translocation is pushed by a virus called Epstein-Barr virus. It drives the cell. And so it's like two different things that happens. It's called the two-hit hypothesis. You need one step, which is the actual infection of the virus, integration of the genome. And the second is this translocation that happens. And you need two hits to turn a lymphocyte into a lymphoma cell. Next slide. Okay, so we'll go to the B cells now. And then if you look at the B cells, there are lots of signals in the body that allow the cells to grow, and there are a lot of signals in the body that prevent the cells from growing. So if you think about a car, right? If you think about a car, it has a accelerator and a brake, and of course, we are also used to clutch. So you call it the ABC, at least in India, when you have a stick shift. So accelerator are in this case, genes that accelerate growth are called proton genes. The genes that stop the growth are called tumor suppressors. And interestingly, in every cell, there are two copies of tumor suppressors. So you have two pairs of chromosomes, right? So you have one pair of chromosome with two pieces. So each chromosome has a tumor suppressor, whereas the proton gene, which drives, is only one. And if you think of all different types of cancer, the problems occur only in these proto-oncogenic processes. There are about 400 genes. There are about 20, 30 proto-oncogenes, and there are about 100 tumor suppressors. And the key one, tumor suppressor is T53. And if there's a problem with these things, the cells grow unchecked. Proto-oncogene grows, it's like an accelerator, a car keeps going, but you can always put the brake. So T53 is the brake. But what happens with T53 is that there are two pairs. If you lose one pair, it's okay. You still have the other set of brakes, the T53, to stop the car. But if you lose both, when there's the loss of T53, then the cells multiply undivided. So basically, that's the genetic process that drives the cancer in this case. Next slide, please. And as shown, they also promote inflammation. Just as you saw in Hodgkin's lymphoma, the cells around it get activated. So they are not cancerous, but they allow those cells to start instigating. It's like inciting a crowd. We see that very often in various situations, and whatever the inciting events are, these other cells get excited and they start growing. And that's the inflammation that you see in Hodgkin's lymphoma. Next slide, please. So the B cells are very important. The B cells are the lymphocytes that help make antibodies. For the rest of the discussion, I'm going to stick to B cell lymphomas because it's the most common type of lymphoma, even though we talk about Hodgkin's. The non-Hodgkin's, the most common type is B cell lymphoma. And in this case, if you look at the genome that is colored and you have pieces of genome that's developing, the developing lymphocytes, when it multiplies, the lymphocyte is like a general in the army. They're supposed to orchestrate many things. The T lymphocytes sit in the room, and then they plan strategy. B cells then deploy the missiles, which is the antibodies, to go and attack infection or a chemical. And it's a very orchestrated process. It's a very fine-tuned process. Next slide, please. And when the antibodies are produced by this process called variable and constant region changes, it's called a VDJ recombination. I won't get into the details of this, enough just to say that every time you have a cold, every time you have an infection, the body goes through this B cell missile production, produces the right kind of antibody, which is able to identify the antigen or the protein, which is the virus, and is able to get rid of it. It also does this for cancer to a large extent, but this is the normal process of B cells. Next slide, please. And once they go through this process, they keep this memory, and from a regular B cell that is able to identify the right kind of antigen with the right antibody, they become memory B cells. And that's a mature B cell and a memory B cell. Next slide, please. The animation is, as you see here, there are different types of antibodies. And if there is a flu, one strain of flu, or a different strain of flu, or a COVID, a different strain of COVID, you are able to have these different switches that allow changes in the B cell. This is called the antibody repertoire. Repertoire is the word that is used for these kinds of things, but you can see at the back end of it, in the machine room, the genomic changes that happen. Next slide, please. And Okay. And this process is called class switching. This class switching recombination, these are some terms. And for those of you in medical school, you have to read this. Robbins is a good book. We have several textbooks of immunology. This is the basic of all of the process that you need to know, whether you're going to see patients or whether you're going to industry. I think this class switch recombination is one of the most important processes. Next slide. And they go, and these are some of the details. They go into this process called somatic hypermutation. And if you think of an analogy, I gave you the analogy of these missiles being produced or arrows being produced, and you have this contest where different kinds of missiles are shot at the antigen. So it's a process that if you have a flu, you don't know what's the protein strain. So what the B cells do is they produce 200 different types of antibodies, and they shoot the arrows at the flu to try and get rid of it. And this process of producing this 100 different antibodies is called hypermutation. And the right antibody that sticks to the flu remains, and that becomes a memory B cell. The other B cells, the other antibodies go away. That's the normal process. Next slide. Okay, you can skip the slide, go to the next one. We'll get to the. Okay. So what happens, and you see there's a lot of genomic events that has to happen very quickly in B cells. And these are not events that happen over a period of time. They happen over a very short period of time. I gave you the example of the genomic events that can go wrong. When you have a gene in chromosome 14, 14 is one of the major loci. We talked about the heavy chain, constant region, heavy chain, variable region. So chromosome number 14 has the heavy chain. So, and that's the machinery that drives the production of antibodies. But let's say a piece of chromosome 18 goes in 6 to 14, or a piece of 8 goes in 6 to 14. What happens in those situations is that instead of creating antibodies, it drives the gene that gets stuck to it. In 14, there's a gene called BCL2. So you have BCL2 overexpression, and that becomes follicular lymphoma. And when 8 sticks to 14, you have a major proto-oncogene gene or an accelerator, and that's c-MYC. When c-MYC sits to the heavy chain region, it becomes Burkitt's lymphoma. So I just wanted to give you the genetic principles to tell you that genomic events are the reason why lymphocytes go from a normal, very highly sophisticated lymph cell to a cancer cell. And of course, there are more details to it, but I want to simplify this. Sometimes you also have genes that are overexpressed, and a good example is BCL6. BCL6 is an overexpression of the gene that you often see in one of the B-cell lymphomas called diffuse large B-cell lymphoma. So I give you 3 good examples of how genomic changes, gross changes in the chromosome with what is supposed to be a very good antibody production process suddenly becomes cancerous because of some issues that is either due to the Epstein-Barr virus or due to the infidelity of the process. Next slide. Okay, so if you look at the subtypes of lymphomas, if you take all the B-cell lymphomas, about 70 different kinds, you can trace them back to the normal B-cell development. If the cancer happens in the cell, in the B cell, that develops in the bone marrow, so all cells of the body, or the red cells and the lymph cells are produced in the bone marrow. That's the factory. And the cells come out of the bone marrow factory, and then they go to maybe the thymus in some cases for the T cells, and the B cells, they go straight to the lymph node. But when the naive B cell becomes cancerous in the bone marrow itself, it becomes a leukemia. And when it comes to the lymph node, you have different types of lymphomas. Mantle cell lymphoma is a lymph node that is destined to go to the interfollicular area. Follicular lymphoma, diffuse large B-cell lymphoma, Burkitt's lymphoma are those lymphomas that happen in the process where it's supposed to identify the antigen in the center of a lymph node. And the center of a lymph node, you have series of arrangements called of follicles. These are called the lymphoid follicles. In the center of the follicle is where the mutational changes that normally happens. Of course, if it becomes cancer, you get the corresponding cancer. And then once it becomes a memory cell and it produces antibodies, but it becomes cancerous, then you get cancers like multiple myeloma. So if you understand the B cell development and you understand the genomic changes and you're able to trace back the lymphomas to the normal lymph cell counterparts, you're able to understand how these cancers behave. So it's a very good illustration of the process. Next step, next slide. Okay, so this is just to give you the entire pluripotent stem cell, which is the cell that's able to develop into any type of hematopoietic cell, either the myeloid cell or the lymphoid stem cell, which gives rise to this. And you can have the abnormal counterparts from this. Next slide, please. Okay, and this is further illustration to show that one of the main reasons why I'm explaining to you is that how are we able to identify these lymphomas is not just by how it looks under the microscope, because in Hodgkin's, you see the Reed-Sternberg cell. The other lymphomas, you see a lot of lymph cells which look normal. So how do we identify them? I told you they're like the generals in the army. So they have stripes, they have stars, and these stripes and stars are the proteins on the surface of the cell. These are called cluster designation, or CD for short. So if you look at the B cell, you have the mature B cell expressing CD19, CD20, CD22. These are the most important markers. And then after that, they also express certain markers like CD40, CD38, and CD40. So it's important to keep the CD19, 20, and 22 in mind, because what we have done is over the years, in the last 25 years, we have developed our own monoclonal antibodies to mark these proteins on the surface of the B cells, and we are able to get rid of them. And that is the immunotherapy component. And not only is this able to helping us identify the cancer cell by the various types of markers, but we also are able to develop therapeutics. CD20, one of the first monoclonal antibody that has developed is the Rituxan. And CD19, one of the greatest therapy that's developed today is CAR-T, just chimeric antigen receptor therapy. So it's important to know the B cell and the antigens. So it's called the immunophenotype. The phenotype is the type of cell. Immunophenotype is the term that we use for this. Next slide, please. Okay, so this is just details to show that CD19 is a marker for B cell, mature B cell, and so is CD20. And we also are able to identify this under the microscope by doing a test called immunohistochemistry, right? And we have now antibodies, as I mentioned, to tackle these. Next slide, please. So CD20 is the most common B cell marker. In fact, to identify a lymphoma as a B cell lymphoma, if you look under the microscope and they look like lymphocytes, they look normal sometimes, but they also look abnormal. When you do the staining and you find CD20, that's good enough for us to say that this is a B cell lymphoma. Of course, the patterns and other things will help us distinguish whether it's a follicular lymphoma, whether it's a diffuse large B cell lymphoma, whether it's a Burkitt's lymphoma. But CD20 is one of the basic tests that you have to do. And it's a simple immunohistochemistry that shouldn't take more than 3-4 hours to do after you look under the microscope. Next slide, please. Okay, we can skip the CD38. It's one of the activation markers. And we can skip CD37. This is just additional details for you to read about later on. CD79 is another important marker for B cell. And the reason I think it's important is that we have another drug that has been utilized that works through CD79. And it's a pan B cell marker. Not all B cells have CD20, but all B cells always have CD79. So now we have a new drug called polatuzumab that targets CD79. And not only does it target, but also drops chemotherapy inside the cell. So there's chemotherapy attached to the edges of the antibody. So it's called an antibody drug conjugate. And that's why CD79 is important. For diagnosis, you don't always need CD79. If you're CD20, you don't need a CD79. But if you suspect that it's a B cell, 20 is negative, CD79 has to be done for diagnosis. So it's good for both diagnostics and good for therapeutics. Next slide. Okay, so finally, I took you through some of the genomics, the principles of cancer, but in reality, when you're seeing the patient, it's a multi-step process. So patient is seen by a person as by a clinician and suspects lymphadenopathy, gets a scan done, sends the patient to a surgeon. Surgeon then does a biopsy. It's very important to know that you always do an excisional biopsy. The best material is excisional biopsy. If you do a needle biopsy in lymphoma, you invariably don't get a good answer. The problem is you need the architecture under the microscope. There are exceptions to this to the FNA, but generally, I think from a surgical perspective, we always want the specimen to be a full excision. The next best is to do a core biopsy, which is multiple passes to get pieces that can be reconstructed under the microscope. So at least my message here is that try not to do an FNA. Do not do an FNA. Try and do a core biopsy or an excisional biopsy. Next slide, please. And as you can see, and then it gets into the pathologist. The pathologist then looks into the morphology, does the immunohistochemistry, looks at Reed-Sternberg cell. If there's no Reed-Sternberg cell, looks at the CD20 expression. And if it's CD20 positive, we call it a B-cell lymphoma, right? So that's sort of this triage process. So as you can see, it involves multiple specialists here, from the general practitioner to the radiologist to the surgeon to the pathologist. Next slide, please. Okay. And you also do additional laboratory tests, take a good history. Sometimes the history that suspect cancer in certain situations. And these are some of the examples. When you do a lymph node biopsy, not only do you look under the microscope, you also take the cells and send them for flow cytometry. You won't spend much time on it. You also do the genomic testing, especially you want to look for that 814 translocation that I talked about, or you want to look for the 1418 translocations. And these days, there are multiple tests. You can actually do the genomics through a very sensitive test called the next-gen sequencing. And that is helpful in lymphoma to some extent, not as much as we see its utility in solid cancers. So it's very important for you to know that looking under the microscope, identifying the cell, identifying the pattern under the lymph node is probably the most important thing in lymphoma. Cytogenetics is next important in terms of priority. Genomics is helpful, but not always helpful. Maybe it's helpful about 10-15% of the time. Next slide. Okay. Next slide. Okay. So if you think about this case scenario, and I just wanted to also give you the case presentation. This is a patient who comes to you because the neck, underneath the neck or the chin, there's a swelling that was noticed 2 weeks ago, and the patient also has symptoms of fatigue. And so you send the patient to the radiologist. You see that the submandibular mass on the right side is enlarged, and you suspect that there is a lymphoma process. You do a scan, and you can look for other areas too. At least from this is a PET scan, which is based on the energetics principle that I talked about. So the cancer cells are inefficient in utilizing energy. In this case, you see that we give this dye with a fluoride isotope with glucose, and it's taken up by all these inefficient cells, and the cells that are actively dividing light up, and that's the principle of a PET scan. So here, the liver lights up. It's more than what's usual cell. The brain lights up because it's normal for the brain to have glucose, right? And then you see the dye going through the kidneys and the bladder. But there are other areas that are also black. Thanks for using the pointer. So the other areas that are black, which makes us suspect that not only is the lymph gland in the neck, but also other areas around the back of the abdomen that have cancer in them. And then you do the biopsy. Next slide. Then you do the biopsy. And so these are good excisional biopsies done by the surgeon, and you look under the cell in microscope. So you either can see small lymph cells or you can see large cells. On the left-hand side is small, right-hand side is large cell, and then go to the next slide. And in the large cell morphology, then you have to think about what's a likely diagnosis. This is just one snapshot. You can see there's some hemorrhage from the process, but you see a lot of similar looking cells. These are the lymph cells. They have the same pattern, large amount of nuclei. There are some histocytes also that are seen. And next slide, please. Sometimes we do the CD20, right? We can also do the flow cytometry in this. What you see on this right-hand side is the flow test, where you take samples of the excisional biopsy, put them in saline, fresh specimens that are then sent to the flow laboratory. They put it through the tube and put different colors to identify those patterns that I talked about. So CD19, the CD20 for B cells, and sometimes CD3, CD2 for T cells. So on the bottom, left-hand bottom, the blue color plots, you can see that those are uh, uh, the immunoglobulins. When the B cells and T cells get stuck in a process of maturation, the production of immunoglobulins, which has the heavy chain and light chain, is sort of disrupted. In this case, you also want to see there's a disruption of the light chains. The light chains are kappa and lambda. You can see the kappa and lambda are very similar, right? And on the right-hand side, you can see the plots. You can see that there is a CD20 on the y-axis, CD3 on the x-axis. And what do you see? You see 5 different colors. You have the green color, which is neither 20 nor 3 positive. Then you have the blue, which is 20 positive, but not 3 positive. Then you have the red, which is 3 positive, but not 20 positive. So your likely explanation is the green is NK cells, which is neither a B cell nor a T cell. The blue cell is a B cell, which is maybe a normal B cell. And the 3 at the bottom red is a T cell, right? And then you have this light blue and the pink, which have a little bit of both. That's interesting cell. And then when you go to the next flow plot at the bottom, which is, yeah. And so, sorry, we'll just spend one second on this to show that you have the CD3 further from the top. You look at the color here, you have a group of cells that are predominantly expressing CD3 and CD5. So in this case, these cells that you see under the microscope, these large cells, and if you look carefully at these large cells, they also have a horseshoe-shaped nucleus. And this is called a hallmark cell. So what I'm showing you is the example of a hallmark cell which the pathologist identifies, and it's a T cell. It's not a B cell. It's not 20 positive, but instead it's a T cell. It's a twist. I wanted to also give you how you identify different kinds of lymphomas, even though B cells are very common and Hodgkin's is easy to identify. T cells are the most difficult to identify. Next slide. Okay, so you can do all these different immunophenotypes. The T cells have these antigens, whereas the B cells have 19 and 20. The T cells have 3, 5. There are 2 common antigens, 5 and 45. But if you look at it, you have 2, 3, 7, 4, 8, 56 for the T cells. So based on this, based on the flow plot, your assumption is that this is not a B cell lymphoma, but it's a T cell lymphoma. It's CD3 and CD5 positive. Next slide. And so if you look at the lineage analysis, right? So we talked about 20 before. CD3 is the most important marker for T cell. It is the T cell receptor, and it's very important because we use the same CD3 for CAR T. We take the CD3 and put it in the immune cell and make it a CAR T. So CD3 is important to know. CD45 is also called leukocyte common antigen. Sometimes it's negative in certain types of tumors. It's negative in Reed-Sternberg cell, even though it's a B cell. It's negative in ALCL. Next slide. Okay, go to the next slide, please. Yeah. So, and this is just a recapitulation of some of the discussions that I had. Lymphomas don't happen all at once. We talked about 2 hits that happens in any cancer. And this is just an illustration to show that a B cell that sort of becomes a memory cell, that's supposed to become a memory cell and produce antibodies, can sometimes not become a cancer right away. It just starts producing abnormal antibodies. And when you look at the test in the blood, you find elevation of gamma globulins. And when you do this electrophoresis or the serum protein electrophoresis or SPECT, you see a spike in a particular gamma globulin, and then you identify this as gammopathy. Right? It can be a monoclonal gammopathy, and a lot of people have monoclonal gammopathy, but not all of them become cancer. But what happens is when they get the second hit, for whatever reason, a second genomic event, then this gammopathy cell becomes cancerous and becomes multiple myeloma. Just to give you another example, we talked about Hodgkin's, we talked about B cells, we talked about T cells, and this is an example of multiple myeloma. Next slide. Okay. And this is just an illustration to show you if you take a lymph node from the naive B cell in the bone marrow as it goes into the lymph gland, and these are the arrangements that I talked about. The germinal center, the most important part to understand the lymphoma biology, is the center. It looks like a flower, right? Flower with petals, an arrangement of these pink structures, which are called follicles. And that's where the center of it is where the hypermutation events happen, the mutation events that are called the somatic hypermutation. Next slide. And this is just to show you all the lymphomas that you need to know of. If you understand this principle, you know everything from ALL, which happens in the bone marrow, to a multiple myeloma that happens in the antibody. So this slide is probably one of the most important slides for you to remember, because not only are you able to phenotype them and trace them to the normal counterparts, but you also understand their biology to a large extent. Next slide. Okay. And these are just the counterpart names. I won't spend much time on it. Based on where they're located, based on the patterns, you give names to them. For example, in the germinal center, the three most common examples of follicular lymphoma, which has the 14-18 translocation, and the Burkitt's lymphoma, which is the 8-14 translocation. Next slide. Okay. So there are multiple treatments for the most part. I won't spend much time on it, just to show you that we've come from radiation. We've also done surgery in certain types. There are certain exceptions in lymphomas where surgery is still important. Radiation, we've moved away from main treatment to supportive therapies. We have been using chemotherapy for many years to cure cancers, including Hodgkin's lymphoma, but we are also slowly moving away from chemotherapy. Why? Because we have smart medications. We have antibodies that I alluded to earlier. We have smart pills that work on the cancer. We'll show you some good examples of that in the next few slides. Next slide, please. So this is a cell cycle, and it's important very much for you to know that the cell goes into a division phase called mitosis, but it also has to think about going into the mitosis phase, and it has to replicate, it has to produce the material. So that's called the S phase. It stops to think between the S phase and the M phase. S phase is also called interphase. So the gap between, after it's divided to going to an S phase, is called gap 1 or G1. And between S phase and M phase is called G2. And if you go click on the animation, if you don't mind. So what happens is that the cancer cell goes through this phase very quickly. It goes from S to M, S to M, S to M very quickly, and that's why it is able to proliferate, right? But when you use chemotherapy, chemotherapy attacks this cell cycle. So whether it is doxorubicin, whether it is platinum compounds, topoisomerase inhibitor like etoposide, it actually affects this the cell cycle. The vinca alkaloids, the Taxol, affects the mitosis phase, so the mitotic tubule inhibitors. So if you understand this, see this picture and remember this, you'll understand all about chemotherapy. So chemotherapy affects cell cycle. Next slide. And what we're going to show you some examples of targeted therapies, which are the smart ways of doing things. It's a long list. These are just principles. MAB stand for monoclonal antibodies. ADC stand for antibody drug conjugates. Those two are very important. And then SMI stand for small molecule inhibitors. And I might show you one example, and we won't spend much time on the rest of the others. So treatments have become more and more sophisticated. So whereas chemotherapy works on any cell that's dividing, that's why you have side effects from that. These monoclonal antibodies, these ADCs, these SMIs are very targeted. They only affect the cell that is cancerous. Next slide, please. And so going back to the B cell development, you have different antigens. So obviously we can develop antibodies against all these antigens and develop a therapeutic. Next slide. CD20. So we talked about CD20, and the CD20 is the first antigen that was discovered that could be targeted. Next slide. And how the CD20 works is by marking the B cell, and it marks the cell for destruction by three mechanisms. Once it marks the B cell, the other immune cells come and attack it. It's called antibody-dependent cellular cytotoxicity. It also makes complements to come and poke holes in the cells and kill the cells. It's called complement-dependent cytotoxicity. And also sometimes can directly kill the cell. So 3 different ways with which Rituxan can get rid of the B cell in this case. Next slide. And so this is just a cartoon. If you hit the next button, you can see the cartoon of how the TIR20 is targeted, and you have a series of cellular reactions. What it actually does is it activates internal circuitry to make the cell. So this is the principle of a lymphoma, right? It's where the BCL2s are expressed. Go to the next click, and you have the antibody, the target CD20, and the entire process is reversed, and the cell actually dies gracefully. Instead of being immortal, it dies. And that's how the principle of Rituxan. Next slide. And these are just examples. And one of the ways it does that is through mitochondria. And the mitochondrial apparatus is very important because the mitochondria protects the cell. So what the cancer cells do is they fortify the mitochondria. And so we have different approaches to target the cell kill, either through CD20 or directly there are BCL2 inhibitors, just small molecule inhibitors, or pathway inhibitors, which can actually turn the switch off of mitochondria. Mitochondria is the engine room for every cell. See, if we shut off the engine room, there's no electricity. The cells die, right? Next slide. Okay. And this is one example that I wanted to show you of how certain pills, the cellulars, every cell has a circuitry. It passes messages from one protein to the other. So it's called signal transduction. Signal transduction is stimuli that comes from outside to inside. And you have to understand the signal transduction in the B cell through the B cell receptor. B cell receptor goes through various signals called BTK and LYN and SYK. The BTK stands for Bruton tyrosine kinase. Now, this small molecule, when it targets Bruton tyrosine kinase, it effectively does the same job as we saw on the previous slides. It kills the activation and the mitochondrial inactivity, and the cell dies. There are several BTK inhibitors that are now made a huge difference in B-cell lymphomas, whether it's ibrutinib, whether it is zanubrutinib, whether it's acalabrutinib, and that's become one of the armamentariums for treating several B-cell lymphomas. Next slide. Next slide. Okay, and this is just an illustration of the mitochondria itself. And if you keep hitting on this animation, you'll see that the mitochondria has an inner chamber and an outer chamber. And the BCL2 protects it from being destroyed. Obviously, if you target the BCL2, the mitochondrial starts leaking. It's a fortress, and it starts leaking. Then it's not able to sustain itself, and the entire cell has to die. So this is one of the ways we found venetoclax is a drug that works directly on the mitochondria. Next slide. Okay, finally, antibody drug conjugates are antibodies, but they have chemotherapy inside them. So they knock on the specific protein, they get internalized. And when they get internalized, they merge with the lysosome. Next slide, you see an animation. So what happens is it breaks down the chemotherapy, and the chemotherapy is released only within the cell. Keep hitting the animation to understand the principle. So this is a very targeted way of giving chemotherapy because it only goes into the cell that has a particular protein. And the drug is brentuximab vedotin, which targets CD30. And there is another antibody drug conjugate for B-cell lymphomas called the polatuzumab, which we talked about, which goes through CD30. There are other ways also to tweak the genes. We won't get into the details. And these are chemical changes in the genome called epigenetic changes. So there are drugs that also target the epigenetics. Next slide, please. I know the animation has taken certain time, but just wanted to show you, and I think I have a few more slides to show you that even though we talked about the biology, even though we talked about genomics, there is a certain uniqueness from the genomics, and there's a gene expression profile. Even for the same diffuse large B-cell lymphoma, you have at least 2 or 3 different signatures, and that can be very important in deciding the prognosis. And this is a good example of identifying a diffuse large B-cell lymphoma as germinal center or a non-germinal center. The germinal center B-cell lymphomas do well. The non-germinal center, the activated B-cell at the bottom, these patients don't do so well. So it's important not only to identify a lymphoma, but also identify the genomics that has a prognostic implication. So there is this uniqueness about every lymphoma that needs to be identified. Next slide, please. Okay, so I just wanted to give you this idea that the reason we are here talking about all these therapies and not chemo and radiation is because we have gone through a lot of clinical studies. Patients have to be enrolled in clinical studies, understand the principles of cancer, the hallmarks of cancer, the different targets, the different chinks in the armor that the cancer has. And I think it's important, an emphasis to say that for us to have more targeted therapies, we need to have more clinical studies. You understand the biology better, which I hope you have, and also be able to enroll patients in clinical studies with all these sophisticated drugs that are available today. Next slide. Okay. What I just showed you is that our understanding of lymphoma is not just a lymph gland with cells that become cancerous. This is a much more deeper biology. It's taken us about 150 years from the identification of Hodgkin's to putting it under the microscope, doing immunohistochemistry, to doing flow cytometry, to do genomics, to get PET scans. Today, I think we stand with, because of all the work that's been done in the last 100 years. Today, it's much easier to diagnose lymphoma. And the reason why it's important is because you can cure many of them. So I hope you have this imagery in mind, and the next lymphoma that you see, you jump on it and try and get them to a cure. I think that's the last slide, and I'll stop here.
Thank you very much, Dr. Swaminathan. So that was a very wonderful presentation, and which was with a lot of animations, and I'm sure all the students and all the general public who have been logged on with us on this Saturday evening would have got a lot of their queries solved already. We have many questions coming up on YouTube and also on Facebook, sir. I'll put you very briefly 3 or 4 selected questions. One of them is a 28-year-old engineer. He's calling from Coimbatore. He's asking, he has a family member who has been diagnosed with a lymphoma. He doesn't tell the subtype at 53 years. And he's asking, what are the early signs of lymphoma, early signs and symptoms, and how can we diagnose early?
Yeah, it's a good question. So if you want to generalize, I would go back to the case history that I presented. Somebody might come with a swollen lymph gland underneath the neck. Swollen lymph glands are not that uncommon. When you get a cold, you have swollen lymph glands. It's only when it doesn't go away, or when the gland gets very, very large. When you have an infection, you give antibiotics. If antibiotics don't treat it, then you have to make sure it's not a viral infection, because antibiotics don't treat viral infections. And despite doing all these things, if it doesn't go away, that's when you go to the doctor and say, do I need a CAT scan? So it's a process. I wouldn't alarm you by saying that every lymph gland enlargement is a lymphoma. You have to be very thoughtful about it. It's a clinical process. You go with this step by step. But many of the advanced cancers obviously have lymph gland enlargement. You have loss of energy, loss of appetite. You have fatigue. You have weight loss. So all these things put together are called B symptoms. So when you start noticing this in combination with enlarged lymph nodes, I would say that's a sign of lymphoma. There is no screening test that we have, like colon cancer or prostate cancer or breast cancer, where we can identify, because these things happen very quickly. So keep these things in mind. The lymph gland that doesn't go away with antibiotics for months, I think you need to look into it and get a CAT scan as a first step.
Thank you so much for answering that, sir. And a quick question. Can you elaborate a bit more? You have already spoken about CAR T cell therapy. So which are the patients you think which should fit into CAR T therapy? Are there any specific subset of your patients whom you'd advise this to?
Yeah, I didn't speak about CAR T because it's another large topic to discuss. But just to illustrate that the same antibody principle, which attacks and gets rid of the cancer cell, the same antibody can be put inside the cell. And so that becomes a targeting. So it's a cellular targeting therapy, but you also make the cell stronger by adding the CD3 that I talked about. That's the motor for the lymph cell. So that's why it's called a chimera. Chimera means you have a mix of two different types of elements. So you have a B cell component, or your antigen component, and you have a T cell component, which is a CD3 in an immune cell. So chimeric antigen receptor. That's what CAR T stands for. And CAR Ts are approved for lymphomas. There are at least 3 different types of CAR Ts approved for 4 different types of lymphomas: diffuse large B cell lymphoma, follicular lymphoma, mantle cell lymphoma, and also you have a CLL, where the parties, they are all CD19 directed. So right now, for diffuse large B-cell lymphoma, you can get a CAR T if the disease does not respond to initial chemotherapy within the first 6 months or within the first 1 year. All other CAR Ts are approved after at least 2 different types of treatments for the patient. So we are also testing to see if there are patients who can benefit from CAR T right at the time of diagnosis. We don't have that information.
Thank you, sir. One more question which I wanted to ask is there something called as a high grade and the low grade lymphoma, or something which you consider, and which lymphomas are having as better prognosis? Probably that would be the last question for today in the view of time.
Yeah, so there are terminologies. Grade used to be a pathological definition of how the lymph cells, and I showed you the picture of small cells and large cells. And you would assume that the small cells many times are low grade and the large cells are high grade process. Just to give you a simplistic version, we have moved away from that, and we've integrated that grading terminology into the morphology, which is how it looks under the microscope. Grading depends upon large cell, small cell, and how the nucleus looks, whether it looks angry, whether it looks, the chromatin is open. And then you have the immunophenotype, and then you have the genomics. So if you, just to give you an example, high-grade lymphomas are Burkitt's lymphomas, diffuse large B-cell lymphomas. Low-grade lymphomas are follicular lymphomas. So just very simplistically, low-grade lymphomas are follicular lymphomas, high-grade lymphomas are diffuse large B-cell, and Burkitt's lymphoma. It's important. Burkitt's lymphoma is probably the highest grade lymphoma because these cells are dividing very fast. They go through the cell cycle that I just showed very quickly, and all the cells multiply. So when you do a test called Ki67, 100% of the cells are multiplying. They have the highest Ki67, which is 100%. Most of the lymphomas have Ki67 lesser than that. Diffuse large B-cell has a Ki67 of 80% or 90%, right? So that's the grade. So diffuse large B-cell lymphoma is high grade, but it's not as high a grade as a Burkitt's lymphoma.
Thank you very much for answering those queries, sir. Now I would like to invite the backbone of Grace Cancer Foundation, our very own Dr. Chinnababu Sunkavalli, to take the proceedings forward. Welcome, sir.
Thank you so much, Dr. Harish, for hosting this. Let me thank Dr. Swami for such an enlightening session. Thank you so much. I know you're going through a very tough hurricane, Beryl, with power off and multiple issues happening there at Texas. I think, it's phenomenal that your commitment, you didn't excuse yourself from, your commitment. And really, thank you so much for very lucidly and simple way you have presented it, so that even a medical student can easily understand what lymphoma is. Really appreciate this effort, Dr. Swami. Look forward to more collaboration. I know you are working on one of the prestigious cancer centers in the world, the MD Anderson, and we look forward to associate with you as well in the days to come, especially in with respect to the global preventive oncology perspective. As the days go by, I think UB at Grace Cancer Foundation would look forward to collaborate much more, especially with respect to the prevention of cancer. And as you know, year on year, Grace Cancer Foundation is conducting the Grace Cancer Run as a kind of an awareness drive globally. We've touched about 100,000 people sign up last year across 120 countries, and this year again it's going to be the 7th edition, which is going to be held on October 6th across the world. And it will be both in person and virtual as well. So look forward to more of your support, Dr. Swami, and we will let you go and take care of your patients. I know that you are very much on call today, and yet you have joined the call, and we look forward for the Nobel Prize effort has come from your institute, your department. I think that is something that is exciting, and kind of giving us some kind of a more motivation to dwell and work more in this field. So once again, thank you so much, Dr. Swami, for your time and for your lucid presentation. Do you want to say a couple of words, Dr. Swami?
Oh, thank you very much, Dr. Chinnababu. And I think what you're doing is phenomenal, from going beyond what you do to take care of patients at the ground level, to prevent cancer through screening programs and education, which I think is very important. And I think we need more efforts like this. India is such a large country, and unfortunately the cancer is rising. So kudos to you and your team, Dr. Chinnababu. that being said, I just wanted to I just showed you the picture. I'm standing right in the library of MD Anderson. The picture that you saw was that of MD Anderson himself, the man who gave money in 1940s to create this large institute. So when you have a chance, all of you should come to this library and look at the historic beginnings in the 1940s to where it is today. So very inspired by that, and inspired by your work, and look forward to working with you.
Thank you so much for inspiring each one of us. Please take some rest and look forward to catch up again. We will definitely, do visit your center, and definitely will also look forward to visit the library which you have mentioned. Thank you so much once again for your time. To all our viewers, both in Facebook and YouTube, look forward to see you at the start line. And if you're in Hyderabad, Gachibowli is the place where I will be having the 10K, the 5K, and the 2K. That's where you see the man, the founder of MD Anderson, someone who has really built this center. Thank you for showing us those visuals. This is something really inspiring, especially for many medicos who are watching this. I think now we are really encouraged by this. Yep.
Very good.
Yeah. Thank you. Thank you, Dr. Swami.
Thank you.
Appreciate it.
Thank you.
Wonderful. Thank you. Thank you, all the viewers, for your time, and look